Hello, my name is Ruben Mesa and I'm the director of the Mays Cancer Center at UT Health San Antonio MD Anderson. And this video is one in our series for patients with myeloproliferative neoplasms. And this is a breaking news video as it relates to the approval on August 16, 2019 of Fedratinib. Fedratinib is a JAK2 inhibitor and now represents the second approved drug for myelofibrosis. In fact, we've only had one drug approved for myelofibrosis in the past. That was ruxolitinib, and now that was almost 10 years ago. Now, Fedratinib is known by the trade name of Inrebec and is produced by Celgene. The drug is approved as a JAK inhibitor, like ruxolitinib, which is in the same class as a JAK inhibitor. The approval of Fedratinib relates to data from the Jakarta and Jakarta 2 studies. The Jakarta study was a randomized study of Fedratinib versus placebo for patients with intermediate to and high-risk myelofibrosis who had a platelet count of over 50,000. And compared to placebo, Fedratinib was vastly superior for improving the size of the spleen in patients with enlarged spleen, improving symptoms. The main side effects on the study related to risk of GI toxicity, specifically some mild nausea, diarrhea, or vomiting. In general, that was manageable for patients. They could take either Imodium or anti-nausea medicines, and in most folks that ended up resolving and not impacting them utilizing the drug. But the drug was very helpful. In parallel, there had been a second study called the Jakarta 2 study. Dr. Claire Harrison and I led that study. And that study was for patients that had previously failed ruxolitinib and then were eligible to receive Fedratinib. That too was beneficial, and recently we've reported data on a more stringent analysis of that study, showing a response rate of about a third of patients that had previously failed ruxolitinib by fairly strict criteria, then responding to Fedratinib. So the approval now on August 16th is for all patients with myelofibrosis, intermediate to and high risk, that have a platelet count of over 50,000. So in which patients will that be utilized starting in the near future? Well, first, most clearly, individuals that have failed ruxolitinib and have no other good option will likely benefit from Fedratinib, particularly if they have splenomegaly, symptoms, or other difficulties. Second, it can be considered as a frontline therapy for patients with myelofibrosis as well. Now, the therapy has a black box warning, and I'll explain what that means in detail. So this drug was tested with these Jakarta studies now several years ago. But the drug had been put on a hold because there had been a concern in less than 1% of patients for developing a rare complication called Wernicke's encephalopathy. That is a state where individuals feel a little bit of confusion and can have the origin be a deficiency in one of the B vitamins or thiamine. Now, the drug was put on a hold, and now it being approved, there is a black box warning. Celgene has put in place a way to try to decrease any risk to patients who take the therapy by monitoring thiamine levels before starting Fedratinib, and people taking thiamine replacement before starting the drug. Second, monitoring for any side effects like that or thiamine levels during the course of therapy with the drug. The hope is that side effect, which had been rare, will be decreased significantly through these efforts. Indeed, even as we had studied those individuals that had been labeled as having Wernicke's encephalopathy in the past, those 8 individuals, we found that many of them probably did not technically qualify as having Wernicke's encephalopathy. An independent neurologist found that probably only 1 out of the 8 truly had Wernicke's, and they probably had that at the time of trial entry. So all of this effort with a black box warning, I think, is through an abundance of caution, which is appropriate, but probably should not really be viewed as a limiter in terms of consideration of the drug for people that might benefit from it. So patients with myelofibrosis are watching this and asking, should I go out and get started on this therapy? Well, as with all decisions, this should really be a discussion between you and your physician. Patients that are on ruxolitinib and clearly doing well, there probably is not a reason for a switch in medication. People that have a suboptimal response to ruxolitinib, again, a discussion should be held with their physician. Is the ruxolitinib appropriately dosed? Should fedratinib be considered? Is there an appropriate clinical trial, of which there are many now, as second-line therapies for patients with myelofibrosis? Overall, the MPN community should view this news as a very positive development. The option of more therapies clearly helps us to help a broader number of patients with myeloproliferative neoplasms. Additionally, the energy and the investment that having drugs be successfully approved in MPNs helps to encourage other investigators, pharmaceutical companies, and groups to invest of their time, their energy, their resources to further develop therapies for MPNs, and hopefully together all of us working for a future in which we can find a cure for myeloproliferative neoplasms. Thank you so much.